Okay. And let me share my screen and I'll pass off this start to Dr. Catlin.
Hi, everyone. I'm going to work off two screens here. So I'm going to open the chat. I can't see your faces or hands. So if anyone has their hand up, Karen, you can stop me. Otherwise, I'm going to keep the chat open so I can see and try to touch on questions as they come up, or we can have some discussion time at the end.
Okay. I'm going to turn off my own camera and just for a network wave, but I'll watch for that.
Okay. So this is session 2 of our course. We're going to talk about asthma medications and device use. Next slide. And we'll run through the objectives of the overall coursework to reinforce skills and knowledge around guideline-based asthma self-management education to support students with their asthma control, to identify children with suboptimal asthma control, and to be able to apply the content areas to support these children and their families. We're through the course talking about using tools to monitor and record improvements in their asthma control and be able to deliver these skills to at least one student and be able to share how we do that as part of the discussion. Through the presentations, we'll share updates from the 2020 NHLBI asthma guidelines, and we'll talk about how to do an Envision walkthrough, make sure you have what you need to get yourself nominated for asthma-friendly school recognition, and then you can use this as a forum for case discussion and questions, as they come up through the presentations, or reach out after, and we can bring those questions and topics back to the group. Next slide. This is our monitoring form, just sharing that myself, Melissa and Karen, who are speakers, have no disclosures, and this course is available for 1 credit, and you can, I believe Karen shared that how to log in to the UVM website to claim your credits. They ask, it'll be up longer, but they ask to try to claim those within 30 days.
Dr. Cowan, on that regard, I just wanted to let folks know that those will be available. Caitlin will circulate those soon, and then we can have some follow-up. And be sure to put in the chat your email if you are interested in credits. That'll give us a backup way to reach you, and we can try to get you those instructions. Thank you.
Thanks, Karen. And then as we go along, if people haven't been able to claim and they're having trouble, you could put it in the chat and we can work on that together, getting to that website and adding it on. It's pretty simple and easy to add your future credits once you're in there. Next slide. So we're just a brief overview of the topics that we'll go through. Last week, we talked about an overview of asthma self-management education and just overview of the asthma basics and pathophysiology of asthma. And this week, we're going to talk about asthma medications and device use. Have some ideas for applied work to go along with the sessions, and this can happen concurrent with the sessions or after the sessions, in terms of identifying children who need to learn more about their asthma or who have asthma that's not well controlled. Next slide. All right, so we'll dive into medications for asthma, and we'll talk about asthma action plans. So for medication for asthma, treatment's effective to control symptoms, to reduce airflow limitation, and to prevent exacerbations. In terms of longer term outcomes with asthma, there can be airway remodeling, which is chronic pulmonary inflammation and irreversible airway changes, followed by premature decline in pulmonary function. In the short term, what we tend to see is more exacerbation, missed school, decreased quality of life, and there's a lot of impacts on life happening in the shorter term, and that's tends to be the main goal of therapy, is to reduce risk in that regard as well. For long-term control, we want to treat the underlying disease, so control of persistent asthma. And for quick relief, we treat acute symptoms and exacerbations. Next slide. So starting with what medication we use, inhaled corticosteroids are the first line therapy. This is the most effective prophylactic therapy because it actually treats the underlying problem, which is the inflammation. So these bind the intracellular glucocorticoid receptors, which affect inflammation, and they also upregulate beta-2 receptors, and which is where the albuterol works. They block late phase reaction to allergen, reduce airway hyperresponsiveness, and inhibit inflammatory cell migration and activation. They do improve asthma mortality rates. They decrease exacerbations, hospitalizations, ED visits, symptoms, airway hyperresponsiveness, obstruction, and then they improve symptom-free days. And then we have inhaled corticosteroid in combination with a long-acting beta agonist. Examples of the long-acting beta agonist are salmeterol and formoterol. And the combination medicines that we use, you can see in this picture over here, would be Symbicort and the generic versions of Symbicort, Dulera, Advair, are what we commonly use in children. So inhaled steroids with LABA, these are more effective at controlling symptoms and improving lung function than inhaled steroids alone. Inhaled steroids plus leukotriene inhibitor, or doubling the inhaled steroid dose when children are not well controlled on inhaled steroids alone. The kids this tends to be helpful in would be children poorly controlled on inhaled steroids alone, and kids having the lead of nocturnal and exercise symptoms. Kids with a higher amount of albuterol use may do well with these type of medications. Some tolerance does develop, and we tend to follow this in plans as we do with inhaled corticosteroids alone. It's deciding if there's times that their therapies can be stepped down. Next slide. So moving on to acute therapy, so commonly need to do this in schools if their kids are recovering from an illness or developing increased symptoms. So for short-acting beta-2 agonists, we use albuterol for acute symptoms and prevention of exercise-induced bronchospasm. This has a rapid onset of action, relaxes the smooth muscle. Most of these devices are made to be given with a spacer. These are all given by the inhaled route for acute asthma management. And these aren't chronic therapies. We certainly do use them regularly for pre-treatment for exercise. That's a different issue than using them for constant symptom management. So this is really for acute therapy or exercise pre-treatment. There's levoalbuterol or Xopenex. There's not typically an advantage with that, but you may see a child have one versus the other due to something particular to that child, but there's not a specific advantage with levoalbuterol. And then we'll go on in this presentation to talk about smart therapy, and that's using inhaled steroid with LABA to take advantage of the LABA for symptom relief during increases in symptoms. And the medication we can use for smart therapy has to be an inhaled steroid with formoterol. That would be Symbicort or Dulera if kids are on smart therapy, and we'll go into that in more detail. Then we have anticholinergics, and we sometimes use ipratropium with acute exacerbations along with albuterol. And then with systemic corticosteroids, that would be a 3 to 7 day burst, typically not a prolonged taper. And in children with those shorter courses, we don't taper at all. This is for moderate and severe exacerbations as an adjunct to facilitate the recovery and then prevent symptom recurrence.
Do you want to pause for a second for any questions? I don't see any in the chat, but I'm just.
I don't see any in the chat.
Okay. I don't see anybody. Okay, go ahead.
So we'll move on to smart therapy. So this is stands for single maintenance and reliever therapy with and that is done only with inhaled steroid and formoterol. Formoterol is a long-acting beta-2 agonist that has a rapid onset of action, so that works in 10 or 15 minutes, same time frame as albuterol. It has a good safety profile. The other long-acting beta agonist that we use is salmeterol. That's contained in Advair, and Advair cannot be used for SMART therapy. So if you have a child on Advair and wonder if this child could be on SMART therapy, they would need a different maintenance medication. So when children have SMART therapy in their plan, they'll have an inhaled steroid with formoterol, so Dulera or Symbicort on their plan. This can be considered for kids with moderate or severe persistent asthma. If their asthma is well controlled with typical plan of inhaled steroid and as needed albuterol, that's okay. It's not a mandatory thing that they have to change to SMART therapy. For some kids, it can be a lot more convenient. There is a high certainty of evidence in kids ages 12 and up, moderate certainty of evidence for ages 4 to 11. When kids are on SMART therapy, they will still take a maintenance dose of their inhaled steroid and formoterol, their Symbicort or Dulera, either once or twice a day. And then in addition to that, they'll take extra puffs of that inhaler and no albuterol. And for ages 4 to 11, the maximum is 8 puffs a day. And for ages 12 and up, the maximum is 12 puffs a day. So that would be over a 24-hour period. And we'll go over some examples of asthma action plans as we go through this talk with SMART therapy. Next slide. So some potential issues with this. So be aware, as we said, only for mometasone formoterol, which is Dulera, or budesonide formoterol, which is Symbicort. Cannot do this for Advair. We cannot do this for other combinations that do not have formoterol in it. Those would not be safe, and they would not be effective due to the duration of action, and they can't have repeat dosing. The reason for salmeterol not being able to do this is the long onset of action. It takes 60 minutes, so you're not going to get a good rescue treatment in that amount of time. Some of the challenges that come up with this is monitoring and follow-up. Some of the office systems that we have maybe seeing how often are kids going through their albuterol inhalers to get a sense of how controlled things might be if they're calling for refills in between their follow-up visits. And if they're filling inhaled steroid with a lot of their maintenance therapy, that tends to be a marker of good control or things are going well. But if they're using it a lot for rescue, that makes it pretty difficult to tell how often they're going through things. The other issue is insurance-wise. So if you may be wondering why someone isn't on this plan, it may be because we just haven't tried. It may be patient preference. And it may be an insurance issue just for practical reasons, because these medicines tend to be more expensive. Some insurances do still have a limit of 1 per month. And sometimes if kids are on daily doses, we can stockpile a bit and have them fill a bit early. But sometimes it really is an issue that the copay per inhaler is quite a bit higher, so it can be cost prohibitive. For children with Medicaid, those are covered to do SMART therapy. They can get enough medication for home and school. But with some insurances, they can get one for home. If they're taking 2 puffs twice a day, it lasts exactly a month. So they do not have extra puffs for rescue or to have a second inhaler for school. So that's something we navigate with the family when we're developing an asthma action plan for them with SMART therapy. Next slide. So we'll go through some other medications and then we'll come back to the asthma action plans and then review the SMART therapy on the asthma action plan. Leukotriene receptor antagonists, these tend to be less effective alone than inhaled corticosteroids, with the exception of some kids who do respond well, but typically this is best as an add-on to inhaled corticosteroids rather than monotherapy. Should be aware of a black box warning for montelukast. This has been around a really long time for montelukast. It seemed to go away for a while, the warning, and then it's been back. So people have been talking about that, but this has been around for a long time. There's behavioral and mood side effects in a small amount of patients. It's reported about 3%, but I think we tend to see it be a little bit higher than that. The effects are transient and they resolve really quickly when they stop therapy. So we do use caution in kids with coexisting mood disorders. It doesn't mean we would never use them, but we're really cautious about that. And if kids are having any mood side effects at all, whether they have baseline mood issues or not, we wouldn't continue the medication. So we ask families to stop it and let us know if that happened. Then we have long-acting antimuscarinic antagonists or tiotropium. Spiriva is the most common medication for that, and we may use that as an add-on if control is suboptimal on inhaled steroid and LABA. And on occasion, we would use it with inhaled steroids if people can't take a LABA. There, some contraindications to that. And then we do avoid it if there's glaucoma, risk for urinary retention, because those could be potential side effects. Typically, this is really well tolerated, and typically we don't have to use this very often. It's approved in ages over 6. The device is a little bit challenging to use, so it takes some more teaching, but we do use it if kids need it for an add-on. So you may see that come up on the asthma action plan. Next slide. The biologics for allergic asthma. I'm not going to go into this in great detail, but you may see some kids who are on Xolair, Nucala, Fasenra, Dupixent. There's a newer one, Tespire, that is for any type of asthma, not just allergic. When we screen for this would be kids with poorly controlled asthma, significant symptoms despite therapy, significant allergic symptoms despite therapy, and eczema. And the markers we check in lab work is whether they have an elevated IgE or elevated eosinophils. And if they have one of those, that helps us decide with their symptom profile and their blood work, whether this is an IgE issue or eosinophil issue, what they may be eligible for. And then further discussion goes into that for what we're also trying to treat. So if I have someone with severe eczema and severe asthma that's not well controlled, then and who has high eosinophils, then Dupixent would maybe the way to go. And that can also be administered at home. So that's sort of the thought process that goes into some of these, but these can work quite well for kids with allergic asthma. Next slide, exercise-induced bronchospasm. So this should not limit participation in activities, and we do pre-treat with short-acting bronchodilators. It does prevent exercise-induced bronchospasm in most kids. If things are not well controlled in terms of exercise symptoms, exercise-induced asthma, it can be an indication for maintenance therapy, even if there are no other symptoms. And we use inhaled corticosteroids for that, inhaled corticosteroids with LABA and montelukast for that. And if kids are having a lot of exercise symptoms and that's not well controlled with pretreatment, that we do often see that as a marker of inadequate asthma control. Especially we can see that in little kids, because that's not something we typically, have. They're active. We're not typically having to take albuterol all day to manage those symptoms. We would go back to assessing their overall asthma control. And so then we'll go on to talk about routine education on asthma self-management. And then the next slide will go to how going through that on the asthma action plan with families when we create those. So things that tend to be helpful for families are education on the pathophysiology and how the medications work, age-appropriate education on the medications, how to identify triggers, referring as needed, so if they need allergy referral, they need weatherization referral, thinking about the environmental factors they may be exposed to, tobacco smoke, pets, other things, how to self-monitor control, managing symptoms, adherence, what's their symptom perception, and then agreeing on the treatment goals. So what do kids need to get better? Is it wanting to improve endurance for sports? Is it less missed time in school? Is it preventing ER visits? And I think this diagram, we talked about this last week. This is what I tend to use to share with patients about how do the medications work when we're talking about the pathophysiology. So I think it does tend to help people to see, okay, in the first one, in the distal areas, what's the normal airway look like? So that wall is not all swollen and inflamed. And you can see when parents understand what's the actual problem with asthma, they hear that picture in the middle, that inflammation there is the problem. And that's what we're targeting with the inhaled corticosteroids to improve. That's why you have to take it every day, because it gets out of the system quickly and then things go back to having that same problem. And that can last weeks to months after having repeat infections or bad infection. So that tends to be the reason we're targeting in that through the cold season. And that tends to be helpful for people to visualize what's actually happening, what's the underlying problem. Because I think people tend to have a decent grasp of those smooth muscles tightening up. Okay, that's where the albuterol works, that's where the LABA works. But they can see there where if things are really swollen and inflamed and those muscles are tightening up, you still don't have a lot of room to breathe and things get really difficult. So I think sometimes just understanding why the medications are there, how they work, and how we might use those can tend to be helpful with helping with adherence and helping to reassure we'll be monitoring how those medications are working for their child. Next slide.
Dr. Cowan, before moving on, I was wondering, your comment here, the second to the last bullet about symptom perception. I know that, you know, from the Vermont Asthma Program's point of view, we see a lot of data that shows over-reliance on rescue and underuse of controller. And I was wondering if symptom perception is at play here in that regard, for being over reliant on your rescue. In other words, do people, to save money, stop taking their controller because of because of symptoms and not feeling symptoms anymore, or do they have an issue with symptom perception that's causing that imbalance?
Sometimes we see that, so the symptom perception can be, you know, having a lot of symptoms and knowing it, but one thing we become concerned about if children are poor perceivers of symptoms. So kids who've had poorly controlled asthma for a long time don't know that their lung function's super low until it gets really low or that they're really sick, and kind of just go about living that way. So they don't know until they're getting a bad exacerbation. So monitoring those kids closer. We have some kids who are sick quite often who don't know until things are really bad. And some of that is, you know, maybe they're flying under the radar and taking their rescue a lot or not being adherent. We'll talk in a little bit, you know, on some of the insurance challenges with medications lately. It typically isn't access to their controller medication there. If sometimes kids are feeling fine and don't take it, or have, you know, worries, if parents have worries about should I give this or not. That typically is the reason for not good adherence, or just forgetting, life gets in the way. But the symptom perception often is that kids that don't know that they have, that things aren't good until that they have an exacerbation and they're really bad, and that can be really hard to treat. And sure, if you're taking a lot of extra albuterol, you may not, there's just a lot to do when things get worse. It gets really hard to treat that way too.
I see.
So being aware of who's a poor perceiver is really important. And if I had someone I know is a poor perceiver, symptom is having symptoms, it's probably really bad by then.
I see. Yeah, thank you. That's very helpful.
Let's talk about making the asthma action plan together, and then we're going to go through some examples of smart therapy action plans, because you may see fairly wide variety of that. So I'm going to just go through how we tend to go through in clinic and making these things. And I think I'm sharing our clinic example. I'm sure that different providers have different ways to go through these. And sometimes things are really straightforward, and it's probably filling out the plan, just passing it along to parents, just to get it done for school. But when we're in clinic going through the plan and having an asthma visit with them, I pull this up on the computer and type it out with them. And then often one of the nurse asthma educators like Melissa will go in and review with them and go through the steps and extra education for them, but just making the actual plan and making sure it fits what parents do and what we intend to do for school. So this is also a good time to review the medications, like we talked about on the previous slide. What do they do? What are they for? Yes, you're going to take them for this long of duration. You're going to take them whether you're sick or well. And then knowing when you're in the yellow zone. So how do you know that? And that, are they able to recognize their symptoms? When would you start taking albuterol? And this would be in an age appropriate way. So for a really little kid, this would be their parents recognizing, for a toddler when they're having symptoms. And then for an older child, that they could participate in that too, to know like, oh, I have a cough, or that's when I'm in the yellow zone. Some kids, it's, if they get any stuffy nose, their parents know it's going to go straight through the chest, and that's when they start up their yellow zone. And for some kids, it really is okay till they get a cough and they can just take it as needed. So knowing their own symptom pattern is important. Knowing what their pattern of symptoms is this more seasonal? Is it just with colds? Do symptoms tend to come on really fast? What do the triggers tend to be? And we talked before about symptom perception, right? So getting to know, and one of the goals we have in clinic, for kids with that is getting their lung function to be really good and getting them to feel really good so that they know when they get sick, when they feel bad. So if they're feeling really good, great lung function for a long time, they tend to make things easier to know when they're getting sick. This is a good time in making the plan to talk about goals of what is sometimes pretty obvious. Like if they have a chronic cough, if they have a lot of exercise symptoms where they're not able to do what they want to do, those are really easy goals to identify, is to say, we're going to do this plan, and what we would like to see is that the chronic cough be gone, not waking up at night, that exercise is easier, those type of things. So as kids get older, if they can participate in what their goals are, that sometimes helps with the adherence as well. Families should have copies of these for home, daycare, school, where whoever needs copies, and then they should have prescriptions for home and school for the medications they need in each place, and then the devices if they need a spacer for their medications. And I'm going to use this opportunity talking about the plan that if there's things that don't fit at school with what you're giving, or something's changed, that's can be a good time to review with the child. Well, if they're coming in a lot for extra albuterol treatments, and they're if it's age appropriate, to check in with the child first, or if it's not age appropriate, checking in with their parents. Are they taking their maintenance medication? Sometimes that's helpful, and that's why the school has that information of what they're on to, so that you have that context of they're not on something, well, maybe they could be. That can be helpful. I'll share an example for one of my kids. When my oldest was in first grade, her nurse had checked in with her actually to see, what are you taking, because she was coming a couple times a day to get albuterol. I didn't know that she was having so much trouble at school, and she went, and the nurse was asking, do you take anything at home? And she said, yes, I'm taking something at home. It's red. Take it in the morning, take it at bed. And the nurse got concerned because she was giving a red inhaler that was albuterol at school. And so she was worried appropriately that she was getting something probably 4 times a day of getting albuterol and may not have something. But she checked in with me about it, and she's taking Symbicort at home. And it was helpful to me to know to check in with her doctor about changing the dose for her, figuring out how to get a bit better. But that was helpful for me to know what's happening at school for her. And it helped the nurse sort out, well, what is she taking something at home or not? The color medications are confusing because it didn't really help anyone out on what it was, but it did help that conversation. And I got in one of the questions I got by email from this group last week was really helpful, and I think a good example to discuss about exercise treatment. And I'll acknowledge, I think everyone probably does these plans a different way. And fortunately, the patient that asked me about was my patient. So I know how I make the plans and what I intend, to communicate, and how I write them with the family. But their question was, what happens? So this child has their plan written. you see this line about 10 minutes before sports or play. That child said albuterol 2 puffs. It did not say as needed. And that child presumably should be coming in before, before their exercise time. It's fine to time that to cover gym and recess. You often don't need to do it for both. It lasts long enough. But that child probably did. When I write that with the family, my personal style would be if I say albuterol 2 puffs before exercise, that we would have had a conversation, the family and I, about it, that they feel that child's having that many symptoms, then we're going to just schedule the pre-treatment, because the majority of the time they need it and they benefit from that, and that would be part of their just standard plan and a safe plan for them. That child and that they were asking about, however, something had changed, and the parents, it sounded like they had said they're actually not needing it for exercise. And that child, I believe, had started up a new Symbicort maintenance. So things might have changed for them. And if you're seeing something's changed that's making it hard to do the school plan, it tends to be fine to defer to the parents, whether, but it's also okay to reach out to, if it's our office or a different office, because something is really different that's making it hard to, know how to document or do the right thing at school. It's fine to get that clarified. So that's something, when I make the plan, I do tell the families that it's okay to reach back out, if we want to take off the scheduled albuterol for school and just say as needed. But I'm also aware people do these plans differently. So they may say as needed for exercise and be relying on the kid to report in. They may not be appropriate for their age and they may need to be scheduled. So those are okay things to get clarified. It's sometimes challenging to get them back from the office or have the parents reach back out, but that's something I would tend to say to make it easier for yourselves. And it's fine to get those clarified for the family. And if it's easier for the kid to just come in, it's better to do that. I would rather have the kid come in and get treated before exercise than be, silently struggling most of the time, or be told, oh, you look okay, you don't need to go to the nurse, when they may actually not be feeling okay, because that might contribute to poor symptom perception if they're been told to just push through all the time. So I just want to people do these differently, but it's okay to reach back out. And I appreciate that question about how to handle the, if something changes on the plan or parents say it's a little bit different. Any questions or comments about that? So we'll go to this example. I think you skip to the next one, Karen. This would be smart therapy example, action plan for a teen. So I have several asthma action plan slides. They all look really similar, but I just want to show you, they look pretty similar. So they all generally have the same spirit. There might be some nuances here, and those are okay. So this is the example of smart therapy for a teen. And this would be someone who you'll see on their plan, they have Symbicort and albuterol as a choice in their yellow zone. They probably will not have both of these inhalers at school. And there can be a couple reasons for this. One might be that the family preferences, I'm not too sure about this plan. It's new to me. I still want the albuterol plan. If it's going okay, I'm going to switch to the smart therapy plan, but I'd like to have both options. So we might see that, or we might see that, yeah, I want to try that plan, but my insurance is going to be a barrier. I think I'm going to probably need the albuterol inhaler for school due to cost. I want these both things written down. So someone may have a plan that has both those things, and it's okay to use whichever that they brought in. And it's okay if, they, make a change later that just picks one or the other because something worked better for them. So you might see both options on the plan. And then the thing for this child, this is a child that's 12 or older because their maximum says 12 puffs in 24 hours. So you should see what's your maximum amount of puffs. This child has Symbicort in the yellow zone, 2 puffs every 4 hours as needed. You can see that written various ways. The actual guidelines are not specific on that. So it's really 1 to 2 puffs as needed with a max of 12 puffs in 24 hours. And depending on the family needs, the school needs, or what I, perceive their need might be at the time. I may write that differently. I've kind of taken to writing that every 4 hours, just so we have a kind of a marker of, well, how often do they need it? But that's really, it can be sooner, and that's really not totally necessary. They can take less puffs, they can give it earlier, but sometimes it's easier for us all to know how often people are getting it. But you might see that written different ways. That's okay. The maximum would be what's pertinent there. Next slide. And then this is another teen example. They're taking Dulera, they're taking, this is just smart therapy, so they don't have albuterol in their plan. And they have Dulera for exercise pre-treatment as needed. You'll see here it's a teen, so their maximum is 12 puffs total in 24 hours. Most people do not need that much, they don't get to that. And I would certainly, if someone has gotten to the max or is having trouble between doses, they would certainly be calling our office to talk through that, or they'd certainly be seeing you, or you would notice that they're in, more often than you expected. So this is a child who just has ICS formoterol for their maintenance in the green zone and for their rescue in the yellow zone. Next slide. So this is a child. And this child is, actually, this would be a teen, sorry, because they have 12 puffs in 24 hours on here. Sorry, that would be a typo in the child. If it's under 12, they're going to have 8 puffs here in 24 hours. But this one is written 1 to 2 puffs as needed here. And this child's actually just turned 12. I remember writing this plan. This is actual child's plan example. So they're pretty savvy with their medications. And at this time, I didn't have it on a schedule. We just did 1 to 2 puffs as needed with a max of 12 and 24 hours. So if you see it written that way and it makes it challenging for school, that'd be okay to reach out. But this is actually okay dosing plan. I think the challenges that rise with school for that is, well, if they're needing it, if they're in every hour, your sense would probably be that's not okay. They're not doing okay, but it doesn't give a parameter about when would I be alarmed. But that is how the guidelines are written, more of the flexibility of it's as needed. Next slide. So this is a teen example again. So 1 to 2 puffs as needed. And then I think we just move to the next one, Karen, because that's pretty, I think that may be the same. And then now we're on the child. So they're taking Symbicort 2 puffs once a day here. A lot of children are on 2 puffs twice a day. This is an example of where this child switching to smart therapy actually allowed them to decrease their maintenance dose. So for this child has allowed them to decrease their overall treatment with inhaled corticosteroids, because ramping up the treatment at the onset of symptoms was enough to treat their asthma well. And then overall, it can reduce their daily inhaled steroid dosing. So they're on 2 puffs a day of Symbicort, and then they take 1 puff as needed before exercise of the Symbicort. And then the thing to notice for this younger child is that their max is 8 puffs of the Symbicort over 24 hours. Right. Now we're moving on to the inhaler device types, and I'm going to try to show some videos. We'll come back to, I think, Karen, if we're going to work on some videos, I'm going to go through this slide and then we can skip to a couple other ones and come back to the slide with the video links and pick a couple. But the most reliable type would be that what you typically see is the HFA MDI that we use with the spacer or in mouthpiece, or spacer and mask. What we're seeing, and you may see this coming up on their action plan for their maintenance, is that increasingly for school age kids, that the insurances are requiring different devices due to them being cheaper for the insurance companies. And we've also then seen kids with lapses in their being able to access medications or not able to do the technique with that adequately. So their asthma control may be less. So knowing about these devices is really important in case kids are needing some instruction about how to use that device properly. Even in our office, we're having trouble accessing, devices to teach with. So the first time they may get the device, it may be at the pharmacy and have to teach with something online. Um, so it is important to sort of know where some resources are for this. So we have through UVM resources for spacer and mouthpiece or spacer and mask. And then the next slide, Karen, there's other resources out there with really great videos on how to use some of these other devices. There are kids who are developmentally not going to be able to use this and are going to need their doctor's office to work on other authorization of the medications they're used to using, but there are some kids who can use these devices. So it's worth knowing where are the resources to teach about these. So this is from Boston Children's Hospital, and they tend to have all of the devices. There's also other institutions too. So if you're looking for a university device and watch them before you share, you can tend to know what's reputable. But the Boston Children's Hospital YouTube, if you type in Boston Children's Hospital YouTube and whatever device it is, you should get what you need. And these are some links to some devices like the QVAR Redihaler, an Ellipta inhaler. That's like a Arnuity, a discus inhaler. So if there's a Flovent discus, there's an Advair discus, Wixella. So those are discus inhalers. There's a Pulmicort Flexhaler. We talked about Spiriva. I tend to use this website to teach people on the Spiriva because that you have to put it together differently. And then the Asthma-Nex Twisthhaler is pretty common. There's probably some others out there, but these are going to be the more common ones. And I think, Karen, if we're going to show a couple of videos, we can pop back to these and maybe choose one if people want to think about which one they want to see. The next slide. Talk about why is it important to get in the medication in your lungs. So the reason that we prefer the HFA MDI and with the spacer and the mask or the spacer and the mouthpiece is because anyone can do this. It gets in really reliably. So even with infants and young children, the spacer and mask, they don't need to do a breath hold and they don't need to be able to generate the force to activate the device. And those are worries we have with the devices that are breath actuated is that little kids just can't do this. And so with little kids, short administration time versus a nebulizer, people do not get in their nebulizer medications very well. That is not very motivating to do, loud, takes a long time, and then it's all over the place. These are very fast and they get in very well. If you're using an MDI, the HFA MDI that's made to be used with the spacer best, that's in this picture here, you lose about 70% of the medication if you don't use the spacer. So it is important that they're using something. It's important on all the devices to check the counter. With the MDIs, they'll still spray just like new if they're on 0. So you really have to look at the counter to know if there's medicine in it. Access to spacers or access to teaching on the proper device is really important because if you don't get it in, you might think someone's, should have good asthma control, but they're not going to. With the mask, the fit would be over the nose and mouth, not covering the eyes, teaching them how to clean their spacer, rinsing their mouth or brushing their teeth after the inhaled steroids. And for kids who have a sensitive skin, which is many, if they have a mask, then wiping the face after. And on the provider side, we have to be attentive about that we're providing enough medications for home and school or enough caregivers. And then that kids, particularly at home, have appropriate supervision and using the devices. Go to the next slide, and then we can pop back to some videos. Okay, so I think this is fairly up to date. There's a few, small changes, but this is sort of helpful, like what's even out there. And I used to have, when we did this piece last year, I had what's circled and sort of what we really prefer, and still really have the preference for the MDIs with the spacer and the mask, but there's some of this really truly not accessible. And if older kids are able to use the other devices successfully, that is okay. I've crossed out some because there are things like the long-acting beta agonists and LAMA combinations and long-acting beta agonists alone that aren't with the inhaled steroids that we don't use at all in children. And some of the other ones we don't use commonly, but if it's sometimes helpful if someone came to my clinic and had a device that I wasn't familiar with, I mean, check out this chart and see, well, what is it if they had the name. So that can be a helpful resource to see what's even out there and what's in it. So you can see like, for example, oh, that doesn't have it doesn't look like one with a spacer, or I'm not sure, I'll look that up to see. So things like a ProAir Respiclick, if someone brings that in, that doesn't have a spacer. So that's okay for them to just put in the mouth. But the other ones like the Ventolin, that will have a spacer, that's a HFA device. So this kind of table can help see, well, what's out there and what to do with it. And then I have just some time for discussion and videos here. Karen has some to show, and I think it's fine to take questions first and then come back to the slide that's two up. And if anyone would like to see a different device that's not the HFA, we can pick one just to show what's there on the YouTube resources. Does anyone have a preference?
Well, I think it might be a good idea just to pause and see if there aren't any questions, either about action plans and administering those in the school setting, or dealing with provider school nurse interaction as it relates to the asthma action plans, and then actually administering medications in the school nurse office. Any questions? Any challenges or issues that regularly come up that anyone wants to share? Give folks a minute for pondering. Or another category of topic is you've been talking a lot about smart therapy. Any issues with understanding asthma action plans as it relates to smart therapy? Okay, it looks like everybody's got it down. I don't see any, there's no questions at this time. Dr. Cowan, do you want to try to go back to those links and pull up one, or what do you think? Did you want to address anything else first?
I think it would be great to pull up. Melissa, you can pick your favorite there if you want to do the key bar or something.
Any requests from anybody?
Karen,
what? Yeah,
Karen, I would do the Ellipta because that's a new one that they're going to start seeing. We're starting to have to order that, so I would throw that one in the mix because everyone's going to start seeing that.
Okay, let me see if it comes up on my system easily.
And it would be good to have them reach out to their provider if you're seeing like they can't do it. Like it's worth working on. They share like try to find ways to best work on it. If they legit can't, their provider may not know.
Okay.
We don't even always hear back.
Right.
Yeah. Let me see. I'm getting a very low volume. Do we need to hear it if it doesn't get louder? Let me see.
Yeah, I do. I just watched it earlier today with a patient.
Oh, okay. I always learn good tips from these, everybody. So the more you can see, like, oh, like don't get it wet, those don't store it in a humid place, right? Those are good to know.
And like wiping the mouthpiece, it's always good educational. When they're sick, how about you wipe the mouthpiece after? Ha ha ha.
I think we can all see this is not the 7-year-olds that they're asking to take this, right? This is like a 17-year-old, like probably more appropriate, but we are having to do this for really little kids.
I did a 8-year-old today. Can't remember.
Any others you want to watch? Any questions on that? Has anybody overseen the administration of Ellipta yet in your offices? Yeah. I imagine it's hard for young ones. Oh, yeah. Kim says none here. But I wonder if it wouldn't be harder because of not knowing. You don't get that feeling that you're getting anything in with the with the automatic.
I think with little ones, it's also the endurance of like continuing to do it correctly each time, and it may not be a school thing, but I think it's something to keep in mind. That you could redirect parents to reach back out to their doctor's office. Something if their asthma is not well controlled, that it's something to ask about if you're seeing one of those devices, or that if parents like it's just not working, we're not giving it. And we see kids can demonstrate one time, but they have to be supervised and they have to keep doing it each time. And with a little one, it is like probably often doing that with them, like physically breathing with them each time, because they're not going to endure to keep doing it right the same way.
Yeah, that's the tricky with this is like the school nurses, obviously you guys are watching them do it and encouraging them. At home, the families are like, oh, just go do it. And that's where.
So we got a request for the Asthma next too. So
yeah. So when these medications were FDA approved for these age ranges in clinical trials, you're having people who are superstars supervising every movement of taking these things, not real life. Okay, so that's why we have better ways, right? That's why we, prefer those other medications, but we're dealing with the insurance realm right now.
Okay, so here's the requested Asthma inhaler.
That's another good point, is that a lot of times the inhalers count down, and oftentimes parents don't know that. So sometimes they think that that's going to go up at 0, 0. So they keep giving an empty inhaler and not realizing that it actually counts it down.
There's also an albuterol one. I don't know if you guys are seeing it, that the counter's on the top and it's really tiny. I've had some parents bring it and say, I don't have a counter. And it's, look close on it if they're saying that. There may be one.
Will you turn the closed captioning on maybe? I mean, there's probably some of it, but
It's on.
is that on? It's on, okay. Because we can't hear it. There's no volume.
No volume at all?
None of them have. I
closed-
mean, everyone's
The
smart.
closed
They can see
caption's
it,
pretty
but
good. The closed caption's
yeah,
pretty
it's
good.
Okay.
fine.
Sorry about that. Yeah.
I live by closed captions, so it's okay, but yeah. Yeah, the Asthma twist healer, you'll see Asthma in an HFA and in a twist healer, and it may not actually specify on their action plan. So that might be a, if you're trying to learn more about what they're actually taking, it could be either.
So we're just at the 4-minute remaining mark. Is there anything else that you want to cover, Dr. Cowan or Melissa? I think the only thing I was going to mention is to again remind you that there is an Ask Me in Schools packet, and a lot of the content focused on today is related to what was covered by Dr. Cowan, which is, knowing your students that are uncontrolled. And this packet offers a checklist of some of the content that you would cover with a student to provide that extra support and reinforcement to bring them into more regular control. And today, early in the slides, she covered asthma basics, but there's also additional expanded content on that. And there are videos in each of these categories that are 5 minutes long that you could actually show your student if you wanted to over 2 to 4 weeks, and when they come in to get their meds. But you can use this checklist just to cover some basic things of what is asthma, what happens in the lungs, or what types of medications has Dr. Cowan covered, but that also goes through the list of like skills and things that you want to do to make sure that they know which of their device is the rescue, which is the controller. And you just run down this checklist. And in doing so, you're delivering this education to the kids. It's an evidence-based list. And that means it's shown to take kids from uncontrolled into control and help sustain that control from anywhere between 1 month up to a year. And this packet can also allow you to just do a little bit of tracking of the information so that you just fill in the school name, the student initials, and then how do you know that they're uncontrolled? Are they having emergency department visits? Do they have a lot of missed days of school? And then you just do that assessment. Are they using the device properly? Are you having a sense subjectively that they're uncontrolled? There's an asthma control score that you could put for an objective assessment using either ACTS test or ATAC or TRAC, one of those tools that gives a score to determine if they're uncontrolled. And then you deliver this content in these categories of basics, medications like Dr. Cowan is running through. And you just put down the dates completed. And then after the content is delivered, you do another assessment to see if there was any change or improvement. And that's what's involved in Ask Me delivery. And it counts as an activity that can earn you points for your nomination of your school as an asthma-friendly best practice. Plus, it helps the kids. So I recommend that if you haven't seen this packet, if you haven't received it, put a note in there with your email asking for it, and I'll send you one. And we just recommend we throw out the challenge, find one student with uncontrolled asthma and try to go through this and deliver it to completion, and then submit the forms to me. So the main focus is on that skills and making sure they're getting that medication into those lungs and achieving control. Dr. Cowan?
I think there's, thanks everyone who's putting your email in the chat for the packet.
Yeah.
Do you see that, Karen? Do you have
Yeah, I
that?
see that.
Okay,
I'll send you a packet, Molly. And the Asthma Friendly Schools nominations are due by the end of May 31st. So you have time to actually do a couple of those activities, including delivering to one kid. Any last questions other than I see it, Lisa. Okay, well, we look forward to seeing you next week. We'll be talking, I think it's triggers, is that correct? Yeah, triggers, I believe.
Yeah, and I think either next week or the one after, let's see if we have some time. I know in the past, Karen, you shared some examples of the Asthma Friendly Schools application. I think that was kind of helpful. People know that what you're already doing is really important for that.
Okay, yeah, we'll walk right through it. So it's very easy to actually do in your own schools. And then if you have any questions or any questions related to medications or any of these topics, feel free to email me and I can forward them to Dr. Cowan and or Melissa. And you can have that kind of consultation and technical support as you go along. Again, thank you, Dr. Cowan, for your presentation today. Thanks, Melissa, for your expertise. And we appreciate all of your attending. And let us know what kinds of supports or areas of topics that you're interested in that can make your lives easier as it relates to asthma. And have a great day. Thanks so much.